Hello, my name is Michael Seid. I am a behavioral and social scientist at Cincinnati Children's Hospital, and I study the healthcare system. My question is, what does it take to make the healthcare system work well for children particularly, but also adults with chronic health conditions? As a social scientist, I see the healthcare system as a human system. It's filled with technology and policies and information, but it's fundamentally people working together. And I'm going to talk to you today as part of the PEDSnet K-12 Scholars about the social science of learning healthcare systems. Before we get started, I'm going to disclose that I'm an owner of intellectual property licensed by CCHMC to Hive Networks Incorporated, which is a for-profit company that provides software and services to support learning networks. I'd also like to acknowledge a list of collaborators, too long to list, but in particularly for this set of content, David Hartley and Peter Margolis, but no less importantly, the faculty, staff, and patients and families of all the learning networks. We've been lucky enough to be funded by a variety of sources, and those are also listed. Main points I want to make today are as follows. Learning networks are communities that facilitate the co-production of health and healthcare at scale. I will unpack that. There is social science behind why these should work. People are programmed for cooperation. There is distributions of the means of production for information, knowledge, and know-how to make these networks work. There are ways to avoid the tragedy of the commons, and there is a way of thinking about organizations called an actor-oriented architecture that facilitates this kind of ongoing community. The other key concept is co-production. It's key for two reasons. The nature of it gets at the nature of healthcare as a service, not as a transaction. You don't go to the hospital and get a unit of care or of health like you might go to a store and buy a unit of a toaster. And it takes two. It's both the service provider and the consumer to do healthcare production and health production. Also, learning networks are complex systems. The way that complex systems work is by the interaction among the parts of the system. And if you change co-production, you change the system. And I'm also going to go over a framework for understanding and improving learning networks. And this is that the actor-oriented architecture suggests interventions that might facilitate collaborations at scale. And I'll show you how we approach that with measures, models, and looking at the mechanisms of action. So the first article you were asked to read was this network organizational architecture to look at learning healthcare systems. And we've shown, that these are replicable scientific phenomena. And if you look at the outcomes for them, you can see that depending on the direction of change, of improvement, the outcomes improve over time in a replicable fashion. This is, very, very cool. But what's even cooler is the idea that these are voluntary organizations. There's nobody telling people to do that. In fact, in all of these learning networks on this slide, people actually pay to be part of this. They're not being paid to do this improvement work. They are paying to do this improvement work. The question is, what's going on here? We ask, why do they work? And how might we make them work better, faster, and at larger scales? There are 7,000 rare diseases. We've got about a dozen of these learning networks. We've got to go faster and make them work better. So what is going on here? Yochai Benkler, who I'll talk about in a second, said it's not intuitive that thousands of volunteers could beat big companies, but they do. Case in point, Microsoft Encarta and Wikipedia. Microsoft Encarta, for those of you old enough to remember, was Microsoft's attempt to create the first online encyclopedia. What did they do? They bought Grolier's Encyclopedia and a number of others. They hired thousands of professional editors. They created a subscription service where you could get CDs or DVDs. I guess they were CDs mailed to you with all of the professionally edited and professionally researched articles on them. Wikipedia, on the other hand, is a bunch of volunteers organized in such a way that people contribute what they want, when they want it, about whatever they like. And although it was ridiculed at first, if you Google Microsoft Encarta, which I actually did this morning, you will find that the first entry is the Wikipedia entry. It says that Microsoft Encarta stopped production in 2009, partly because Wikipedia was a better and free product. So why should this happen? Well, there's a lot of basic science here. And we talk about the basic science in terms of biological systems. This on the left is biochemical pathways, maps, and on the right is a system diagram of Cincinnati Children's. The basic science of biological systems is chemistry, biology, physiology, anatomy, medicine. The basic science of healthcare systems is clinical epidemiology, psychology, sociology, organizational dynamics, political science, economics, statistics, informatics, improvement science. There's a lot of science here, and I'll highlight some of these. The first point is that, why should people cooperate? Well, Martin Nowak and David Sloan Wilson study evolutionary biology, and they have formalized the ways that that cooperation works, and have theorized that that cooperation is a force of evolution. David Sloan Wilson is famous for saying selfish individuals outcompete other individuals within groups, but altruistic groups outcompete selfish groups. So if you are in a small group, may the most selfish win, but banding together in a larger group and acting in the interests of that larger group beats anybody else. Yochai Benkler, who I mentioned, has said that the production of information, knowledge, and know-how that used to take large capital investment. If you wanted to publish a book, you had to have a printing press. If you wanted to publish a movie or create a movie, you had to have a movie studio. Well, we all have printing presses and movie studios in our pockets now, so that the distribution of the means of production of information, knowledge, and know-how has been accomplished. And not only that, but people will produce information, knowledge, and know-how for non-market reasons. They will contribute to Wikipedia without pay. They will do all kinds of things without a payment. And Eleanor Ostrom took on this notion of that you can't have cooperative ventures because of the tragedy of the commons. The tragedy of the commons is this notion that in a commons where everybody's grazing their sheep, each person has an incentive to graze one or more additional sheep. As a result, the commons is overgrazed, the commons collapses, the sheep dies, tragedy. And Ostrom took that on and said, yes, that actually is the case if nobody talks to each other. But if you talk to one another and you can come up with a shared purpose and ways of enforcing the rules around the commons, then these kinds of cooperative ventures, these communities, are actually very enduring and resilient. Øystein Fjeldstad is an organizational theorist at the Norwegian Business School, and he has talked about an actor-oriented architecture that facilitates the development and optimization of these kinds of communities. And I want to spend a little bit more time on that because I think this is a key set of ideas. So the nature of an actor-oriented architecture is that if you want to have if you want to have a nimble and collaborative organization, you need to have three things: actors who have a shared purpose and the capabilities and values to self-organize, renewable and expandable commons where the actors accumulate and share resources, and protocols, processes, and infrastructure that enable peer-to-peer collaboration. We've actually shown that Improved Care Now, as one example, has instituted changes in their learning network that created an actor-oriented architecture over time. So there are more people involved, there's more sharing and more collaboration, and it's easier to form teams. We've also looked at this at the level of the network itself. This is a tool that we use, maturity grid assessment, that provides a self-assessment of process maturity in 6 different domains. And then you can make comparisons across learning networks and within learning networks over time. And so when we start to look at these learning networks and look at the variation across them, look at the ways that they might be organized and so forth, you might say, okay, well, collaborative learning health systems or learning networks work, and maybe the network maturity grid assessments have some relationship to how well they are working and how well they achieve their outcomes. So in other words, we can start to look at the relationship between how the networks are functioning and their outcomes and start to learn about them. But we're at the point where we don't really know how to advise people who are running the learning networks. We typically do 6 or 8 different things in developing and running learning networks. And our current recipe is do all of the things as hard as you can. And that is one way to do it, but I don't know if it's the best way of doing it. It might be a very inefficient way of doing it. It might be best to do things 2 and 3 first, and to never do number 6 until 4 is at least halfway there. Right now, we are learning based on this kind of observation. And if we were to try to run trials of different interventions to improve outcomes, to improve the learning network, it would take a really long time and a lot of money. So one of the things that we've been developing is a model system of learning health systems. And in this case, an agent-based model, which is a computer program in which artificial agents, in this case, doctors and patients, interact based on a set of rules within an environment specified by the researcher. So recall that that co-production is a key idea. So we had to figure out what we meant by co-production and model and program that. And then we could look at different ways that people interacted. We could look at different characteristics of people, and we could run simulations of various different initial starting conditions over time. So just to give you a sense of this, we took the theory on the left-hand side here, the theoretical elements of the chronic care model, of various elements of the actor-oriented architecture. Translate those are instantiated in the learning networks as change concepts. So in the middle column, implement all aspects of the chronic care model, align people around a shared goal, create platforms for creating and sharing common resources, and then they're represented in the agent-based model in terms of parameters. So you can see how that is translated from the theory to the concepts that the learning networks work to instantiation within the agent-based model. and just to do a very brief, we did a very brief study of computational and face validity of this model, translating this theory into the model. So the theory is that the more involved people they create and share information, knowledge, and know-how for making better decisions, which allows people to get what is needed when it's needed to act in ways to improve health and healthcare. In the model, we can translate that into the degree to which patients influence one another to become more engaged, affects the overall patient population engagement, which increases the availability of shared knowledge in the model, in the network, and that improves outcomes. And so when we actually run the model, which we did here in these next graphs, you can see that patient influence on the x-axis, when we multiply it and divide it by whole numbers, that's the blue dots and the red dots, you have more patient influence means more patient population activation. So as patients are more likely to influence others, overall the level of patient engagement increases. And here, as the level of patient engagement increases on the x-axis, that leads to more shared knowledge. And then as shared knowledge increases on the x-axis, that is related to better median patient outcomes. And this last graph is just a box and whisker plot looking at decreased versus increased patient influence on outcomes. So we have an idea now of how to understand and improve learning networks. We think that shared processes, shared resources, and shared purpose, the elements of the actor-oriented architecture, facilitates co-production and allows people to act in ways that are consistent with their inherent motivations. I've shown that we can measure learning networks with respect to a maturity model. We can demonstrate that learning networks are creating an actor-oriented architecture. We have a way of measuring engagement, which I didn't show, but we also have a way of modeling potential interventions. So we have an idea of how to proceed to improve the functioning of learning networks. And in fact, we have a potential laboratory that is very, very large, over 100,000 participants in 43 states in 5 countries participate in learning networks. So if you think about the types of research that could be done in learning health systems science, if you will, basic and fundamental questions about what they are, how you measure them, models like the agent-based model, mechanisms of action like increased engagement, you can take those and translate them into interventions and then implementation research in the real world, making the learning networks run better. And that is my story, and I'm sticking with it. Thank you.